So in this video, I want to talk about some of the treatment options we have for major depressive disorder. With all the different medications in the market, how do we go about picking one to start a patient on in the first place? Or when do we augment therapy? Or when should we change therapies altogether? It can get really confusing, and so we are going to look at the data from the STAR-D trial. If you're not familiar with STAR-D, it gave us a really good stepwise approach and sort of this algorithm we can follow that shows us how we can get a patient to complete remission, which is our ultimate goal when we're treating depression. So the reference on the screen here, this is just referring to the review article that was published after all the data was in. There was some preliminary publications that were put out, but I want to look at the trial after it was completed in its entirety. So the inclusion criteria, the patients obviously had to have major depressive disorder. They had to be 18 to 75 years old. And patients also had to have a score of 14 or more on the Hamilton Depression Rating Scale at baseline. If you're not familiar with that, it's a questionnaire that patients will fill out and answer, and it gives the physician or clinician basically a score that they can use to, one, show whether or not a patient is depressed in the first place, and also it shows them the severity of that depression based on their score. So some exclusion criteria: patients were excluded if they had bipolar disorder, they were OCD, basically any other kind of psychological issues that could compound the effects of the major depressive disorder. Patients were also excluded if they had recently had a hospitalization due to suicidal ideations, and also were excluded if they had a contraindication to the medications that were being used in the study. So quickly looking at some of the rating scales that they used, or the questionnaires in the study, there was the Hamilton Rating Scale of Depression, like we said before. That is scored a 0 to 7 gives you no depression. A score of 8 to 13 means you have mild depression. 14 to 19 is moderate. 20 to 25 is severe. And 26 and higher is very severe. The other questionnaire they utilize quite a bit is the Quick Inventory of Depressive Symptomatology Self-Report, which is a 16-question questionnaire. And because they needed the two studies to kind of be interchangeable, or the two questionnaires to be interchangeable, they came up with this conversion table, and the scores they came up with were no depression was 0 to 5, mild 6 to 10, so on and so forth. So looking at the actual treatment algorithm, patients were started on citalopram, SSRI, and they either had complete remission on citalopram and were just sent off into the follow-up period where they were monitored, or if they were seen to still have their depression or need further treatment, they were moved on to step 2, which step 2 consisted of either adding bupropion, buspirone, or cognitive behavioral therapy, or patients could be switched to a completely new medication. They could be switched to bupropion by itself, sertraline, venlafaxine XR, or cognitive behavioral therapy by itself. And then again, of those patients, if the patient reached remission, they were sent to follow-up, and if not, they were moved on to step 3, which in step 3, the patients could be switched to nortriptyline or mirtazapine, or they could have lithium or T3 added on to their current therapy. And then step 4, for those patients who still had not met remission, they were moved into step 4, which was a MAOI, which we don't really use anymore, or they were put on venlafaxine XR plus mirtazapine. So if we look at the results of the study at the very end, 36.8% of patients were considered to be in complete remission of their depression at the end of step 1. Now, of those patients who continued on to step 2, 30.6% of those reached remission. Those who were in step 3, 13.7%. And then those who made it all the way to step 4, 13% of those patients reached remission as well. So all in all, if you were to calculate all the numbers for all the patients that treated remission versus the initial number of patients in the study, it ends up being about 2/3 of the patient met remission, just using the medications that were listed in this study. Now, some things we have to consider: patients with comorbidities. So if a patient has, for instance, cardiovascular risk, we may not want to use an SNRI especially something that's really selective like milnacipran or something like that. Patients, we have to consider mechanism of action. So if a patient's on citalopram and they're getting some benefit from it, it may be a positive thing to add on bupropion, because now not only are we reaching serotonin, we're also affecting norepinephrine and dopamine. So we're hitting all three neurotransmitters that we think about when it comes to depression. So we have to think about how these drugs work so we know which ones to augment with. We also have to think about drug-drug interactions along with kind of compounding side effects. So if a patient is already at risk from other medications for QTC prolongation, then we probably don't want to necessarily put them on citalopram. There's probably better options. We have to think about what medications they're on, what their formulary covers, if they're insured, all of those type of things. We also have to consider using these questionnaires. So every person that's on an antidepressant needs to have some sort of way of following their results, and other than just them giving a verbal "I feel better." So these questionnaires are something that are not always utilized, but they definitely should be. And it doesn't have to be one of the ones from this study. PHQ-9 is a really good one. PHQ-2 even can be used. There's several. And this actually paints a really good opportunity for pharmacists. So a pharmacist doesn't have to give a patient this questionnaire and then go through with them and discuss the results. Even if the pharmacist just kind of describes what the questionnaire is for and tells them to take it home and go over it on their own time and then bring it with them to their next appointment, that can be beneficial. There's a real opportunity for this in retail and community settings. So we see a lot of patients in the retail setting where they may be asking a question about their antidepressant, or you may notice that a patient who's been on an SSRI is now being augmented with something else as well. And that creates an opportunity that we can have that discussion. And maybe they've never filled out one of these questionnaires. Give them two. Have them fill out one that they tell them to fill it out that night. And then give them another one to say, hey, in 3 months, fill out this other one. And then when you go follow up with your doctor, then you bring both of these questionnaires and show them how you've progressed. The physician may not need your help, may not want your help, but if nothing else, it just encourages interprofessionalism, and we should be taking an active role in the patient's care, so this presents a really good opportunity. So that's kind of all I wanted to cover. Let me know if you have any questions, and let me know if you have any personal recommendations that you've used in your clinical experience for treating patients with depression. Thanks.